Thank you, Abdul, very much for your presentation and for giving us some ideas on how some countries have tried to design pro-poor policies. I'm having a real problem here, and we have a problem, but I'm so lucky I will pass it to Julie now, because we see all countries trying to benefit the poor. We see that there's still huge inequality in health outcomes, and particularly in this region in Latin America. And so what's wrong? What is happening? And how is it going to move forward? Are we going to be asking more and more the judicial to solve all our problems? Julie. I'm going to introduce you because I did forget that. Julie McLaughlin, she is a health specialist, a lead health specialist at the bank. She's the manager of South Asia, and she very graciously agreed to discuss this very difficult panel. Julie.
Thank you. I mean, this is a subject on which I am no expert, but am fascinated by, and found myself Friday in Delhi in an interesting audience talking about what I anticipated getting out of today's session, which I had hoped to be attending throughout and wasn't able to. But it really is so many provocative thoughts come to mind when you listen to these three presentations. I mean, the session title struck me this morning as I picked up my folders for the meetings I was to go to, and it's on the right to health and universal coverage. There's a presumption that the two are linked. There is a presumption that making it a right will help us achieve universal coverage, and I think that's the question we're being asked today. How much evidence base is that is a appropriate mechanism for getting to universal coverage? And from where I sit, and we sit in different places, from where I sit, that is the goal. That's the presumed objective in our sector. The World Health Report that came out last year on universal coverage opens with a chapter, or at least the last draft that I read, opened with a chapter which really led one to believe that you just have to declare health to be a right and declare universal coverage to be the state aim, and it will be. So that the big hurdle is just making this the goal and setting the right. I was at a conference last week with UNICEF, and I find we're often at odds, the bank and UNICEF, because as a few people have pointed out, we come at it very much from a health economist perspective. What's the affordability? What's the maximum benefits that can be attained? Keith was talking about that as I came into the room. And UNICEF but it's rights. We are about the rights-based approach, the rights-based approach. And that means something to a lot of people. There's a lot of people in here from Latin America. My husband is a Mexican physician. This means something to him deeply. I grew up in the United States. There is no presumption of a rights-based rights to health in the U.S. That was drilled home to me not too long ago when I was, actually I remember the actual incident was he was putting an acupuncture needle into my neck, and a doctor who I had seen for a long time for chronic care here in the U.S., a Chinese-American doctor, I would also note, said, in just talking about the efforts of health reform, the problem is people actually think there's a right to health care. This was a physician who was treating me at the moment, and I leapt. But it really drilled home that in his peer group, this is a very odd presumption that there would be a right to health care. And which also exemplifies the challenges faced in the U.S. reforms that we may hear about any hour. The countries that I mostly worked with in Africa, Asia, East Asia, the South Pacific, started with an implicit assumption of the rights to health. They didn't enshrine it in legislation, but the dialogue I was always having with countries from the mid-'80s was about their presumed right to health, their presumed systems that provided health to everyone. So I can remember in my first days at the bank, a lot of the conversations are, what share of your budget are you paying for health abroad? Very large share was often going, especially in Africa, small countries in East Asia, to care provided abroad. Who got care abroad? Never the poor. Who got care abroad was first politicians, then who could get access to the government officials who managed that pot of money, often not held by the Ministry of Health, to finance care abroad. When we drilled down on this and brought it to people's attention, nobody ever wanted this made explicit. Our implicit healthcare system, Julie, is that we provide everything for everyone, which of course resulted in obviously implicit rationing going on, which has been exemplified by much of the work done by the bank, a lot of it led by Abdo, that this is not a pro-poor way to go at all. So does making this explicit, does making it a right, does enshrining that in a legislation help bring it out? And I mean, from my viewpoint, the whole objective here is holding government accountable for something, right? This is what this is about. It is a governance and accountability aim to enshrine this right, not in UNICEF rhetoric or in protests in the streets, but enshrine it in a legislation. So it is about improving the degree to which we can hold government accountable. In settings where government is still challenged by any of its own accountability mechanisms, I find this quite fascinating. The ability, I just came from the launch of a new health project in Uttar Pradesh. This is a state in India of 200 million people, some of the worst health indicators of the world. Actually, it was pointed out to me, if we can change the health indicators of Uttar Pradesh, we've changed the MDGs of the world. And the whole project is about governance and accountability. A large part of the project is actually on bringing in people with a legal background in sitting inside the Ministry of Health and helping them cope with the demands that have been generated by a population who now brings a lot of things to the courts. And there isn't a explicit right to health care in India, but there is now an expectation and an ability to some degree of the courts to enforce the right to quality, right? You can hold a doctor liable. You can hold a facility liable. This is a big evolution in this setting. In many countries where I've worked, this is just an inconceivable thought, that you could go to the court and say, my spouse died due to poor medical practices. This is the first horizon in some of these settings to say what we can now demand for, what we have a right to, is to be treated correctly. To deserve at least the best the provider is able to provide given their knowledge base, the standards of global quality standards, if not access standards. The capacity problem was really highlighted, the capacity of the courts. And I think what the main question raised here to me is, well, the overall arching question of the session is what degree this helps us be pro-poor. To what degree is this an equity mechanism? And I think it was very nice to hear from Varun that if you said the wholesale actions of the court can have an equity mechanism. They can help raise the standard for all of us. It's the principle, before you said it, I was writing notes to myself of trickle-down theory. So it's okay if the rich get rich because we'll all benefit. But you've describe the actual mechanisms by which that happens in this context. If the courts legislate on behalf of changes in standards for the population, and everyone can now demand it, if the courts in India have opened up the legislation and said you can hold your providers accountable, it changes that dynamic. And it is a mechanism for improving the governance and the accountability function. But I come back to the capacity challenge. Most of the countries that I'm working with, the capacity of the health sector to even begin. And I heard this a lot, even when we were talking about Colombia last, that I was in a session on this issue of a rights-based approach. The ability of the sector to implement the legislation is whether that's a financial ability, whether that's a technical ability, whether that's an institutional capacity, which is the first binding constraint in the settings in which I work. I would say it's not the financing, it's not the it is the institutional capacity. Then do we want to go to the courts and say, okay, we can't manage, so can you develop the capacity to take this on? What I heard in the presentation from Colombia some weeks back was, from the court's perspective, we don't want to be the institution that takes this on. We don't have that capacity, and we should not be developing that capacity. So where does it lie? There needs to be a third party often. It's not good enough to turn over to, we always say, the health sector is not going to reform itself and hold itself accountable. Somebody else must hold itself accountable. In many settings, it is the insurance companies who take on this role. So the mandate comes, the provider is held accountable by the intermediary, who is often an insurance company. Where is the institution where we want to put our development efforts on in this effort towards achieving universal coverage? what is the right place for us to be trying to build that capacity and competency. And I think Abdo said it last, it's going to differ in every setting we're operating in. So knowing the starting point and the social construct in which we operate. I go back to if I'm talking to Dr. Tam here in Washington about whether or not there is a right to health, it's a very different type of starting point, as the U.S. reforms are showing us, than if I'm in Mexico or if I'm in India. Thank you.
Thank you, Julie, very much. I don't know if the Master of Ceremonies will allow me to have one question from someone. Do we have time for that? We have time? Okay. So if anyone has a question for the panelists or the discussant, you have 2 seconds to decide. All right, very well. So thank you so much for telling us so many aspects of this very challenging issue. And Julie, you touched something that has been in my mind for a long, long time, since WHO also put together this book telling everybody that universal health coverage is important, which many countries have been trying to do, as Abdul was explaining, and that we all know and understand that any policies that are put in place have to be really well thought in terms of the capacity of countries to deliver for progressively for all the population and not just a few. So that in that sense, we don't ask the judicial to resolve all the problems that we have created designing policies that countries are really not able to implement, but asking the judicial to help to keep the government accountable for what the government promises. So thank you so much.